Head trauma is a very common cause of visits to the emergency department in children. These are in order. The most common causes of head trauma are motor vehicle accidents. There is a reason why we recommend seat belts and car seats. We're going to take this moment to discuss what the recommendations are. We recommend that the first ride home be the safe ride, and so we recommend the car seat from birth. As soon as the patient is going home, they should be in the infant seat. The infant seat should be in the rear of the car in the center. That way it protects it from side impacts, and it should also be facing toward the rear because of the baby's poor head control. So again, a developmental consideration. The infant seat is turned around to face forward when the baby is 1 year old and 10 kilograms. The patient will then stay in the car seat until they are 4 years old or 40 pounds, at which time they can go to what's called the booster seat. And now it's recommended that you stay in booster seats till older ages. Patients are recommended to go 7, 9 years of age to booster seats. The child can ride in the front seat if there's a passenger side airbag when they are 12 years of age. So those are safety recommendations. The next most common cause of head trauma in children is going to be sports. So they can have headbutts playing soccer or football, whatever. They can be riding a bike. You need to wear a bike helmet. That would be under recreation. Everyone should wear a bike helmet. People who are rollerblading and skateboarding should wear appropriate protective gear. And then violence is the fourth most common cause of head trauma in children. The presentation depends on the type of injury. Patients can have no loss of consciousness or a brief loss of consciousness or a long loss of consciousness. They may have headaches. So it just depends on the type of the injury. We know that children, the more severe the injury, the worse the signs and symptoms will be. Physical exam, look for a linear or a depressed skull fracture. You can actually have to palpate the head. There will be some swelling possibly over the fracture. You can also see signs of basilar skull fracture, and they love to ask names on the exam, so please remember the battle sign. Battle sign is the hematoma that is seen in the mastoid area, and that is indicative of basilar skull fracture. Raccoon eyes, they look like black eyes. That is also indicative of a basilar skull fracture. Look in the ear canal. Hemotympanum is blood behind the ear. You can also have drainage from the ear that is cerebrospinal fluid, or you can have drainage from the nose that is cerebrospinal fluid, and that's all indicative of a basilar skull fracture. Sometimes the fluid can be mixed with blood, and you don't know if it's cerebrospinal fluid or blood. You can always check the discharge and check for glucose, and if there's glucose in there, it's probably cerebrospinal fluid if it's clear and has glucose in it. But if it's bloody and has glucose in it, you don't know if it's the blood sugar or the CSF. So what's recommended then is called the ring test, and you take a drop of that mixture, you put it on a piece of filter paper, the blood will stay in the center, and you'll get a nice circle or a ring that's kind of yellowish around that. That indicates that you have a CSF leak. Again, basilar skull fracture. When we talk about concussions, we need to grade them. Concussion is usually a period of brief unconsciousness and then normal arousal. But they're graded into grades 1, 2, and 3, and they're listed for you there. And it's a stepwise increase in severity of injury. Grade 1 is just confusion. Grade 2 is confusion plus amnesia. And the third one, or grade 3, is confusion, amnesia, and loss of consciousness. The recommendations for returning to physical activity or to sports depend on the grades. So if you have a grade 1 concussion, you have to observe that patient for 20 minutes. If they are fine after 20 minutes, no symptoms, there are no signs, they can go back and play. If they have a grade 2 concussion, you have to have them asymptomatic for 1 full week. And after they've been asymptomatic for an entire week, you wait another week, and then they can resume activities, sports. A grade 3 concussion, you have to be asymptomatic for 1 week, and then you wait an entire month after they've been asymptomatic for a week before they can return. And that's because of the increased severity of the injury. Other head injuries include the epidural hematoma. These will require CT scanning. You may get a test question that talks about a child falls on the swing set and has a brief loss of consciousness, is now brought to the emergency department, and his neurologic exam is absolutely normal. What do? You still are going to get a head CT on this child because of that loss of consciousness. So you want to make sure that there's not some other bleed causing problems. If there was no loss of consciousness, you're probably okay. But the key phrase there was that there was loss of consciousness. Or if it was unwitnessed and you just know that the child had fallen, you don't know if there was loss of consciousness, you must get a head CT. The epidural hematoma, typical presentation is there's a loss of consciousness, usually very brief. Then there's the lucid interval. And the lucid interval depends on the time frame, but they'll have a lucid interval and then they will have another episode of loss of consciousness. So look for on the exam a child that, for example, is playing baseball, gets hit, knocked down, out for a little while, is up again, feels fine, and starts playing again. And minutes to hours later has another episode of loss of consciousness. Look for an epidural bleed. It depends on how fast the bleed is expanding and creating pressure in the brain. That will determine the lucid interval. The CT scan will show what's known as the lens-shaped bleed, and we'll show you pictures in a second. The subdural hematoma on CT scan, look for what's known as the crescent-shaped bleed. Cerebral contusions on CT scan show up as little punctate hemorrhages. Another concept that you need to know is what we call scawara, and it's basically a mnemonic, and it stands for spinal cord injury without radiographic abnormality. Children, their vertebrae are very lax, and you can have, for example, a cervical spine injury where the vertebra will move forward and bump into the spinal cord and then come back into position. And so on normal films, the vertebrae are all in place, but there could be a spinal cord injury. The patient will probably complain of some tingling or numbness. The best test to determine scawara is an MRI of the spine. Here is a patient with an epidural hematoma. You can see that it is lens-shaped, and it's causing a little bit of compression on the ventricle here. These are subdural hematomas, and they describe the crescent shape. It kind of follows the outline or the curvature of the bone. And this one has major compression. This ventricle is completely obliterated on this side. Here is a progression of it at a different angle or cut, and again it follows the curvature of the bone. So this is the crescent shape. These typically, this one is causing compression, will require surgical evacuation of the hematoma. Another accident that can occur is drowning. Drownings are a very common cause of death in the pediatric population. Typically two age groups, the toddler, 1 to about 4 years of age, and the next group is in the adolescent, particularly in males, the 15 to 19-year-old. When we talk about males there in the slide, we're talking about males, adolescent males, because of risk-taking behavior. It is a little more common in blacks, and certainly, again, in the older population, it is related to drugs and alcohol and risk-taking. Most drownings are freshwater drownings. Why? Because most people have access to fresh water and aren't necessarily at the beach. Drownings can occur anywhere. They can occur at the beach. They can occur in your bathtub. They can occur in a bucket. Particularly toddlers, they have a high center of gravity. They tip over and they fall head first, and now they can't get back up. So like a 5-gallon bucket can be lethal to these children. They can occur in canals, in hot tubs, anywhere. This particular sign is a warning for bucket drownings. It doesn't take a whole lot for the child to fall in and then he can't get back up. You really don't need to focus much on dry drownings versus wet drownings. All drownings really start out as dry drownings. You have a laryngospasm to prevent aspiration. At some point, you get ischemic and you relax, or you try to take a breath, and then water comes in. Don't worry about saltwater versus freshwater drowning as far as pathophysiology. The bottom line is that both types of drownings cause anoxia and ischemic injury to various tissues and organs, the most important one of them being the brain. Treatment for drownings is basically supportive. The main thing we can do is prevent drownings, but once it's occurred, it's going to be supportive treatment. Prognosis is difficult to establish. Less than 5-minute submersion usually reveals a good prognosis. Greater than 25-minute submersion is a bad prognosis. The need for CPR and resuscitation right after being pulled out of the water is also a bad prognostic factor. A Glasgow coma score of greater than 6 will be a good prognostic factor. Prevention is the most important thing we can do for drownings. It's not just a matter of teaching children how to swim or constant supervision. You can't keep an eye on a child all the time. It's a matter of having a self-locking gate and a fence around every pool, and just being aware of all the complications. Burns will mostly be covered in the surgery section, but we do want to just give you a brief review. Remember, the types of burns are first, second, and third degree burns. A first degree burn is just of the epidermis and is comparable to a sunburn. A second degree burn causes blistering. And in a third degree burn is a full thickness burn. It burns away the nerve endings, and therefore it should be an anesthetic burn. You really don't feel anything with a third degree burn. Sometimes burns can progress from second to third degree. You need to remember the Parkland formula for fluid resuscitation. You are probably not going to get a regular fluid and electrolyte problem except for this one. The Parkland formula helps you to calculate the deficit that you need to start replacing, and the way the formula goes is 4 milliliters per kilo times the percent body surface area. And what you need to remember is when you're calculating the percent body surface area, 2 things. For the Parkland formula, you only use second and third degree burns. First degree burns don't count in the Parkland formula. The other thing to remember about when you calculate is the rule of nines changes with children. It's not the same as in adults, and it changes actually in the ages of children. So they probably won't ask you to calculate the percent body surface area burn because it could be an infant versus a 10-year-old. But they will give you a percentage of burn surface area, and you need to remember first degree doesn't count for the fluid deficit calculation. Also remember pain management. Those burns hurt for the most part, and those children need pain management. Most burns will already be colonized, so you don't really treat with antibiotics empirically. There's a specific definition of the wound being infected. And also remember your tetanus prophylaxis. That is a dirty wound, and so tetanus prophylaxis should be considered. Here's a child with burns. You see some whitish areas. These whitish areas are third degree burns. Okay? And then these reddish areas are second degree burns. Do not calculate redness in the skin like a sunburn, like probably down here. This is probably first degree. That does not count in your calculation for the Parkland formula.